And we're back, right? Some time ago that we had a session together, Robin.
Absolutely. Great to be back
Yeah.
on not on the raw video screen, at least.
Yeah. I thought we could just start off with a disclaimer as well, because there's a round of getting new money into the company. So we will not be touching on that subject because Robin has then been working with Västra Hamnen. So I think we'll keep those questions to that forum. You'll finish that process, and then maybe we can have more question and answer sessions in the future rather than now in the middle of before closing the options. We'll try not to touch that subject today. I want to be on the right side of the legal matters. Or
Absolutely, Markus. We just continue in our good old GIST tradition that we focus on the science and on the operations bit, on people that are interested. And, there's a lot of information outside regarding this, the wellness option that we're doing right now. So we leave that, as you say, for Westerhamn. I'll give a presentation tomorrow. We'll be out on the website tomorrow around noon for a little more detail about the quarterly report and financial aspects. This one is, as always with Markus, very non-scripted kind of question and answer, what we're doing, we had some presentations, the neuroscience paper published on our clinical trial and so on. And I think Markus will shoot some questions at me, which I might or might not
I
be
think
able
I have
to
plenty
answer.
of questions.
Okay.
So, but shall we start with some context? Because we don't know if the listeners are new. We have done a couple of episodes. I believe this is the 7th episode, but to bring some
Correct.
context, if there would be new people, what is CIAS, cognitive impairment associated with schizophrenia? Could we start off there?
Absolutely. So schizophrenia, is a mental psychiatric disorder. It starts in early adolescence. Usually, it is a lifelong disorder. It's an disorder where the symptoms are. You can have positive symptoms, so-called positive symptoms, where people suffer from hallucinations, exaggerated input in the sensory system. You can have negative symptoms. People withdraw completely. They don't care about the rest of the world and literally sit in the room, stare at the wall. And you can have cognitive symptoms, and that is people are unable to understand the world around them anymore, i.e. cognition. So the signals that you get from outside, you misinterpret them and you're not able to decode them, process them, and give them back. And so the behavior seems odd, strange, and that is what one of the core symptoms group in this particular disease is cognitive impairment, i.e. you have problems with cognition. And cognition in general is something that the way we perceive and understand the world, the way we react to it. And that is, of course, a deficit in many psychiatric disorders. Classical example I always say is Alzheimer's disease, where the cognitive part, i.e. learning and memory, is very much deficient. So
Then I
that's the
have this
context for
follow-up
CIS.
question. I'm pretending I'm this new person who's looking into the company or want to know a bit more. So why does GABA or gamma oscillations matter then when it comes to this?
Well, in general, as a newcomer to GABA,
Yeah.
Markus, brain is a balancing act between an excitatory and an inhibitory system. Once this balance is gone, either too much excitation or too little inhibition, or the other way around, you have some sort of a disease or pathological process, and the brain communicates in certain so-called oscillations of electrical activity in the brain. Different regions literally communicate to this other in a network fashion. And some of them, they have a certain frequency, and some of the frequencies are gamma frequencies, certain frequency band, and the GABA receptors, as the brake or the inhibitory system in the brain, modulate those. And so is there a deficit in this kind of band transmission, to put it simply, because of deficit in GABA activity? Then a GABA enhancing compound can perhaps ameliorate that and restore the balance. So it's always about the homeostasis in the brain, excitation versus inhibition.
Yeah. And something else that I was thinking of, can't you then talk, what's GT002? Because you say it's a partial positive allosteric modulator, right? Compared to a
Correct.
full,
Correct.
if you look at
Absolutely. Absolutely.
current.
So,
Yeah.
it's like, again, to make the analogy to a car, a full allosteric modulator, positive modulator would be something if you put the brakes in your car while you're driving full down. If you
Mm.
have an allosteric partial modulator like ours, you're just tapping the brake very slightly, in order to, again, to come back to the balance between excitation and inhibition. And GT002 is a very selective modulator and a very weak one as compared to a full, if you would say, put on, again, your foot full on the brakes, as compared to ours, you're literally just tapping very slightly, but in very specific areas of the brain, as we know now with GT002. That's a big difference,
Mm. Yeah, that's maybe taking me down on a road. You mentioned that this one is the positive one, and we have seen a
Exactly.
poster that is gonna be shown. And
Exactly.
this one is positive, 002, but you
Yeah.
should have a negative one as well, right? That's 005. Is that correct?
Exactly. The poster in the neurosciences meeting, which is on our website, we have started to present some of the preclinical data of the pipeline, because we always only speak about GT002, and this is not a one-trick pony kind of company, but we also have in the pipeline a compound GT005, similar structure to 002, same 00 series, and this compound is actually a negative modulator. So what it does do, when GABA comes to the receptor and wants to do its activity, it inhibits this activity, in particular combinations. So it has an opposite effect to GT002, which is positive, but that doesn't mean that the clinical effect, what we want to see, has to necessarily be negative, because there can be some disorders, if you think about it, that certain of the areas of the brain or certain networks of the brain are inhibited too much. Then you want to do is block that inhibition, in a way. So you sort of reset again. I come back to the same thing. Then you're resetting it back to the homeostatic level.
Something else I think I saw in the poster was you mentioned this neural fingerprint. Is that correct?
That's right. Neural
Yeah.
fingerprint is it's a little bit of a um, it's a very big topic, and it's very encompassing. What it basically is a snapshot of the activity of the brain at a certain point in time. And what we have seen in the paper that we are working on and going to publish very, very soon, or GT induces a certain neural fingerprint, a very specific condition of the brain, which is very, very interesting for schizophrenia and other disorders involved with cognition. And this particular neural fingerprint is different to the other drugs and comparator drugs that are available that also work on the GABA receptor. So this neural fingerprint allows us, in the same way that you have a fingerprint of a person, if you're looking for somebody who committed the crime, you have a very specific, this goes down being specific for GT002, and is specific to inducing a certain pattern, fingerprint, that can be beneficial for treating a disease, hopefully.
Okay, so what you kind of mean is then that the fingerprint is 002 itself, and then you could look at how that fingerprint applies to different circumstances. Is that what you're saying?
Exactly. That's exactly what what I tried to say, which you have summarized brilliantly in one sentence, which took me 5 minutes just to talk about. But the whole thing is exactly that. You have a certain disease state, you try to put you impose the fingerprint of GABA there, and in that way, you reset it back into healthy. That is our vision, our philosophy, why we're doing so much about the neural fingerprint. And to add to the neural fingerprint, now that you mention it, we have actually published a press release and submitted a provisional patent application, because that finding that 02 induces that kind of pattern in the brain in the healthy volunteers looking at EEG and fMRI, that was new. Nobody has done this before. 2, it was unexpected. No expert in the field could say, aha, GT0 is going to do that. And number 3, I and patent support believes that this will also be useful. So there we have the 3 key elements that you need for an interesting pattern or a good chance to get it granted eventually,
Yeah.
So we put our foot in the door very quickly, submitted it. It's already at the USPTO. So now we got 1 year to add more data to that. And at the same time, we will publish the scientific paper to be reviewed, peer reviewed, that is the basis for that patent, but we have to put the patent in first, because if you publish the paper first, then you shoot yourself in the foot with a.
Yeah, yeah. So I kind of have this follow-up question because you have done the studies before with voluntarily healthy individuals.
Yeah.
How can you take the fingerprint of GT02 and say that maybe it could be good for this indication as well? Is it then based on prior studies and prior
Yeah,
research papers then, or?
yeah, exactly. So it's based on the literature said, okay, if you induce this kind of pattern, you will have, for example, a more relaxed state, or you will have, better filtration of incoming sensory input into the brain. That makes us, optimistic that there's a fair chance that this can actually work. Will it actually work? We don't know. We're in experimental medicine, Markus, and we will see when the first patient comes in. The baseline of the patients, we don't know. How will that be when you put the GT002 and look at the EEG pattern and the EEG pattern? How will that look like? We don't know yet, but we know what GT002 does in healthy volunteers. So we hope that it can then restore the balance in the patient. Then that would be then a fantastic. This is what I actually really wish for and dream for, that GT00 could induce that, because then it's really a really, really, really good story. If you think about the storyline of GT002, we know it's safe, we know it's well tolerated, we know it goes into the brain, we know it induces a certain pattern that is relevant for the disease, and we're going to start testing them in exactly that disease and cognitive deficits. Perfect.
Mm, yeah,
That is it does hang together, and the neural fingerprint is just so important for me, because uh, uh, the behavior, language, whatever part of cognition that you're thinking about, each cognitive process belongs to a certain neural fingerprint, a certain pattern. If I say a word or speak in one language or another, other parts of your brain will be activated. So if somebody puts you into an fMRI, Markus, and you speak Finnish or you speak Swedish, you would have two different fingerprints, different time.
yeah. So I guess then if we take this fingerprint, because in one way you're gonna test it then to see if it's actually gonna get the effect that this
Exactly.
neural fingerprint is gonna say in the
Exactly.
TOTEM study.
Exactly. So, the neural fingerprint has to be, you know, if you say, let's say you have a certain pattern in a disease state, right? Say you have one frequency that's too high, and that reduces that frequency, then they got a good chance. Okay, if we combine these two, too high and a reduction, then maybe GT00 can normalize, for example, that frequency in that part of the brain.
Mm. Yeah.
So you have a temporal aspect, you have an intensity aspect, and you also have what part of the brain is affected, what network. It's like super, super complex. But the fantastic thing is that you're literally looking, it's a window into the brain, this kind of imaging approach, this kind of biomarker approach. You're literally looking how the brain, the state of the brain in a certain condition, be it speaking, illness, health, imbalance, out of balance, and there's a lot of literature on this. I mean, I haven't invented this term,
Yes.
neural fingerprint or neural signature. I wish I had. But for example, you have a completely different neural signature in your brain if you, for example, meditate or you are not thinking. You have a completely different signature if you start talking, thinking, have other activities, and your brain starts actually working. Different networks get activated or deactivated. That is what we hope we can look at G002. We can look at the other compounds once we get so far. Do they do a similar pattern in healthy volunteers? And then we can take a look at what diseases to use them in.
Then we can off the protocol. I read in the Frontiers website they had released the protocol for the TOTEM study.
Yes.
And then I'll have this follow-up question because you said during different phases or during different activities you would be able to see different activation levels.
Yeah.
And isn't that part of that study? When I read the protocol, you had different types of activities to do under each
Exactly.
visit, right? Is that correct?
Exactly. Exactly. So exactly. So they are, you can give them different tasks, and then you can see the reaction to the. So you're looking not only at a static condition, but if you give something like a task or an activity, then you of course also see the dynamics. If you give this activity, how is that neurosignature then modulated by placebo versus GT002? So.
Mm.
And remember that it's a very sensitive, and that's the nice aspect of the study, is that if each patient in the one that we're going to publish, each volunteers is its own control. So you're comparing the activity of the same person against the same person just with GT002 or a placebo or another drug. So you're not comparing one big group of people with one kind of treatment and another big group of people with another kind of treatment, but you're doing it linear on the same person receives 3 different treatments, and then you compare on that particular person, because like a fingerprint, a neurosignature is also individual. So yours is different to mine, different to anybody else. So
Yeah.
So you yourself are your best control on the effect on you.
Yeah, and that's what's interesting of the study as well. And if you really go into the nitty-gritty, something that I wasn't really thinking of, because how GT002 is formulated, right? You cannot have it in the same capsule as the placebo
Exactly.
and the candidate you're comparing towards, right?
Right.
So you had to design around that, and there's a lot of small details that me as a layman wouldn't not thought about.
The complication, the nitty-gritty, it starts already much before. It starts with the production of the material, all the way into how this is handled, by whom, how does the capsule look? Is it really controlled? Can anybody find out what they're actually receiving if it's supposed to be
Yes.
completely blind? What about the taste? What are they going to do about that? You have to mask it somehow.
Yeah.
If something is very bitter and the other thing is very sweet, well, then the guy knows immediately, oh, you're giving me the sugar tablet. So maybe then he reacts differently.
Yeah.
But these people are clever, and there are ways around this. Clinically, you can add something that everything tastes the same or whatever, or you can, I don't know, cover the eyes so they don't see what they're actually ingesting if the shape is different.
Yeah, because I saw that as well, because one could be, in a tablet, and another one becomes more, I don't know if you would say like omega-3 oil capsule-like.
Absolutely. But I can tell you that from a production point of view, if you really want to do everything virtually identical, then the cost will become astronomical, because then you have to reformulate also your comparator drug and your placebo into exactly the same shape, and then you can start asking yourself, okay, if the readout is so sensitive to placebo effects, then it becomes difficult to see an interesting clinical effect. That if you can induce the same readout by looking at something that has the same color blue, then it's maybe a little bit too sensitive.
Yeah, but I thought it was quite nifty how you solved it, that you would have like 2 clear capsules, 2, I don't know, coated ones, or what you would say, and then you would have the placebos alongside of them. So you would always take all of them, but you wouldn't know what's what, if everything is placebo, if one has something. Because that's also something maybe we should mention. Within the study, you're testing both 1 milligrams and 2 milligrams in 2 different visits. Is that correct?
Yeah, exactly. So it's the idea is, of course, to keep it
Unbiased,
but feasible.
Yes, of course.
The challenge. I'm not a clinician, I must say, but just by pure common sense, the challenge is actually to keep the patients returning to the trial, because it's rather a long trial. It takes a couple of visits, and if you look at the statistics of clinical trials in Europe in general, there are not many trials that literally finish the trial with as many patients or people that are being tested as they start with, because people just simply fall off. So there are many clinical trials are notoriously tricky.
Yeah. So I'd like to tie this, because we talked about excitatory and inhibitory imbalance. Like, what would you see? Because you said that you're going to compare to yourself, right? So what would the deficits be for a person, like compared to a healthy volunteer? Would you see any tendencies between someone having schizophrenia and someone who doesn't have it between the tests?
Yeah, definitely,
Yeah.
Markus. You would see that. And also remember that many of these people are patients that are receiving other medicines at the same time, you
Mm.
know. And we don't know, okay, how does that then look on an EEG pattern? And that's again, that's why you need to have each person as their own control, So it's even, I think, even more. I wouldn't say 100% necessary, but a good strategy, a very good strategy to get proper data out, because
Mm.
it's not an enormous amount of patients. We are not talking about hundreds of people being included.
It
It's
was
right. It's rather
20
few.
patients and 30
Exactly,
volunteers, is that correct?
exactly. So the people have to be informed. They have to be agreeable. Not everybody likes to participate in clinical trial. So
Something that I was thinking of, because when I read the protocol, we talked about the brain signals or markers and so on. And then I had this question, will you look at if you would relieve symptoms, or is it just a neuropsychical level? You would only look at the EEG and
I
fMRI
I
and so
don't
on.
I don't think that you can look at symptom relief, and you shouldn't either, because these are people that have a very severe illness for quite some time,
Mm.
and to expect that GT002, I think, is a good drug candidate. So I think it will trailblaze the way for exactly that kind of studies, where you look at symptom relief, which is actually what we want to do.
Yeah, but I think that's for me as a layman, and I guess for the audience as well, it's quite important to know, and that's why this
Absolutely.
neural fingerprint is so interesting, because it's kind of validating the neuropsychology behind this,
Exactly,
to see that
exactly.
you get the
So
right
that's the idea.
signals.
Exactly.
Yeah.
So that is exactly, Marcus. That's exactly the idea, And if we, it's like two steps, First, we have to see, uh, okay, can we induce this particular neural signature with putting our GT002 fingerprint on it? Good. Once we are there, then can we then correlate that, as it should, with symptom relief in schizophrenia,
Mm.
And that will be
Some
then many more patients, much larger trial, much bigger volume of everything, long-term treatment, maybe higher or lower dose. I don't know. You're standing here literally at the forefront, at the very beginning of science. This had never been done before. This is a new drug, and I think it's very exciting also. Super
yeah.
exciting.
Something I was thinking of, for example, if you look at some other diseases, it's quite say homologous patient group. It's very easy to categorize them, but in schizophrenia, it's not always that clear, right?
No, no. For example, remember those the patterns of symptoms that I mentioned at the beginning: positive, negative symptoms, cognitive symptoms. Well, there might be people that have mainly negative symptoms, but not so many cognitive symptoms. There might be another group that is mainly cognitive, but actually they're still reasonably interactive. So the variation, everything is a Gaussian distribution curve. So you will have a very broad one in the case of, what symptoms you can actually look at, or what group, if you want to group the patient. So it's again, it goes back, that is why, if you can keep every individual as its own control, in my opinion, again, I'm not an MD, is very important, and
Yeah.
a very good approach.
But then, yeah, it kind of just continue to make sense with this neural fingerprint then, because at the same time, you could look, I guess, across the patient, because they would have different symptoms, but you could see, are we inducing the right effect in one way? Because you're not getting their interpretation as a person, because that could vary a lot between different patients, and that would
Absolutely.
take a long, long time to make that such a study.
Then we need to, I don't know, you need to, remember also that, even the neural fingerprint is also depending on, on the or the technical background that you're using at one particular site, So, you can have a study and then the others you do another study in, I don't know, another part of the world, and people say, well, we don't see this kind of effects. And then you can start arguing, oh, okay, are we looking at the same stuff? Are we using the same, I don't know, frequency bands, technology, whatever, So again, it's opening the door a little bit with this particular study under these conditions, but the information that you can take out, that you can then deduce from what we get out, is absolutely, extremely valuable, and particular for drug discovery, in my opinion. I'm really trying to not to pioneer, but to push it, because I really believe that this is the approach that one should go in drug development. Is a window into the brain. You're actually looking at the activity, and it's the activity of the brain that determines your cognition, your emotions, basically your entire you. I don't have to go into, I don't know, a metaphysical philosophy, but you know what I mean. It's a biological basis of thinking. Yeah.
Something I was thinking of, it feels like a kind of a silly question, but I kind of like silly questions. So we're increasing the GABAergic inhibition, right? What happens, like you're testing with 1 and 2 milligrams. What happens, like if you could think that, like what would happen if you would just continue increasing it? You won't do that in this study, but would there be any overly suppressing brain activity in one way?
Yeah, that's actually not a silly question. It's a very good question, Markus. But because it brings me back to the beginning when we said, okay, this is a partial positive modulator, right?
Yeah.
So it doesn't matter if you can only push your brake in your car only that far, and then it'll block. Then it doesn't matter how hard you push on this side. If you put 1 or 2 or 10 milligram, it won't budge.
Yeah.
It
So
won't
when you
get
talk
deeper.
about the half braking, then if we take it to what you're gonna compare with in the study, that one goes full throttle and you'll start become sleepy and so on.
Yeah, exactly. It has another profile, so you shouldn't do that with a comparator drug that is a full agonist. Don't do that. It's not a good idea. For GT002, you can get other effects. If you do anything too much, it will always have a bad
of course.
effect.
Yeah.
Within reasonable limits, like the milligram or 2 milligram you're talking about, in a partial, you won't get the bigger effect, then never mind how high the dose is. The definition of a partial agonist, you will always only get the partial effect on the GABA receptor.
Yep.
And in that sense, remember that GT002 and this drug, they're very potent. So we already, I think, if you look at it from the receptor level, we're already quite close to getting relevant pharmacological concentrations at that level.
What does that mean? In simpler terms, what does that mean? Are you hitting it so
that
precise?
Means, if you have something that's very potent and occupies the receptor, it doesn't matter if you put a lot of other stuff around it, it's already occupied, it doesn't really matter. And I put even more around it, it doesn't matter either. It only gets interesting once you get in equilibrium with, okay, you have nothing, then you will get a balance that becomes interesting. But as long as you have sort of an over a certain threshold, then you got to saturate it. But because being partial, the effect will always be that 10 or 20% stimulation of the receptor. It will not be more.
Yeah. Yes. I guess then with the half time and so on within the body, it would be easy then to start finding
and then
a
eventually,
profile.
Absolutely. And then eventually, it will sort of decline. And thank God, GT002 has a good half-life. So it's, the question is not only to get it into the brain, but the hope is also, thank God GT002 does that, to get it out again. The last thing you want to have something sticking irreversible to your brain, takes 5 years to get out of the brain. That's not good at all. And GT002, actually the pharmacokinetics are good at that. You can give a daily dose. That's what we did in the previous trials, looked at multiple doses, multiple ascending doses. Does this accumulate? And it doesn't. You can wash it out again. And in this particular trial, you have a washout period between the different treatment groups, because you want to make sure that you settle the brain on completely. There's no previous drug around. And then again, you do the next treatment in the same person once you have sort of cleaned out or washed out the previous treatment.
Yeah. Then we kind of touched on the subject, but I think it could be a good thing to clarify. So why did you start with the acute dosing rather than a long-term treatment? Because we kind of talked about it, right? You could see the patterns early on, but why
Yeah,
not combining it?
well, the acute dose, first of all, it's a question of feasibility, do a long-term study. It is not the answer we want to do now. We need to get answered first is, does the pattern that you induce with GT002 in these patients look promising for further treatment? And if it does, then, absolutely next step will be then long dose. Then you will look at symptom relief, for example,
Okay.
You treat 30 days,
Okay.
So this is 2A phase. It's an experimental, exploratory study to see if this is, and I think that's it might be the long way to get to your goal, but this is definitely the correct way, because if we get results that show that there's absolutely no effect of anything, then you have no ethical motivation to do a 30-day trial and treat people with something that will have either no or negative effect. So it's also again, if you think about GT002, we have to really literally develop this step by step by step by step. So single ascending, multiple ascending, imaging study. Now we do an exploratory inpatient. But then, of course, this then opens the door. The stronger the fundament is that you're standing on, the higher you can jump, basically. And that's what we're trying to do, make a strong foundation of what we can do in the clinic.
Yeah, I had this follow-up question as well, that it's a single dose, right? Couldn't there be variability in that? Let's say if I have a good day or a bad day. So you said that I'm gonna benchmark myself against myself, but what would happen if I come in with the bad mood one day and I get the dose? Then you still have the 1 milligram and 2 milligram, but is there any risk in that?
Definitely there is, Markus, but that is something that is inherent in as soon as you go to the individual level in any trial of anything. I cannot exclude that. That's why you need the only way is of course, again, to compare the same person with himself in the case of you. But of course, if you are sort of up and down, and one day you're completely manic, and the next trial day you come completely depressed, then I have a problem, So that is something I can't really control.
Yeah,
Having said that, the interesting thing will, of course, then be, your neural fingerprint will also be different, and then we can compare the change that we induce with whatever we give you be significant.
But isn't that something you could take in the statistical part, that you would give your mood right before doing the test, during the test, and so on? So I guess you could start doing statistical analysis and starting to skewing the data and finding trends in that as well.
Absolutely. I mean, but then you can, the only way is from a procedural point of view, that you try to be as
nice as possible.
Uniform in the way you treat everybody in exactly the same way. But even that is difficult. I mean, placebo and nocebo effects, they are just a reality in clinical treatment. So
of course,
if you write on a package that this will induce headache, and I give you a sugar tablet, you will get headache. Some people will, at least.
And then I continued reading this protocol, and question that came to me is that what happens if the neuropsychology markers improve but the cognitive tests doesn't? Or vice versa, for example. Let's say the cognitive test goes up, but you wouldn't see it in the other markers.
I don't know.
Would that be able to happen?
I mean, then there would be definitively a reason to march on into a larger trial, because then you still need the next jump. Okay, you got these markers, but then what about the symptoms? So
yeah.
Then we have to go back to GABA approach, which is let the data drive you where you are. If that is really the case, then you can design either the next trial in that direction, looking at other markers. Again, if you do something for the first time, You literally have to see what happens.
Yeah, of course.
You know how it is with the saying about
It's a proof of concept, right?
predictions. They're very difficult to make, particularly about the future. So in this case, it's impossible for me to say.
Yeah, of course, of course. I was thinking that then why do you use an active comparator in this case for this study, and why did you pick just precisely the one that you picked in this one?
But we use this one because it's a compound that modulates exactly the same receptor. It's clinically well used, well described. You know, there's a lot of background on this, and it's for 02 in particular. It's very important to also differentiate the effect of GT002 from the standard of care. If you have compounds that already work, well, then it's not so interesting to do more of the same. But we've already shown that we will have differences in the neurosignature with GT002 compared with anything that is around. So that's already a good start.
Of course.
So we only want to then, you know, confirm this now in patients. Remember, this is the first time that we're actually working with patients, people that are suffering from schizophrenia.
Let's say if you wouldn't have had schizophrenia, then could you have picked any other kind of comparator? Let's say if you would like to go towards some other symptoms, like would there be any other?
Definitely, definitely. But then, you know, then at least at the beginning, people would accuse us, but then they would comment, yeah, but you know, then you're comparing apples with pears. It's
Yes,
not
of course.
fair. Okay, fine. So then we use something that is extremely similar in the way they act on the brain, the same receptor. Okay, not exactly the same, but similar as it gets. And then you see a difference, and you're really differentiated from anything else, really, because if you talk about another neurotransmitter system, say you want to work on the glutamate system to restore the balance, then it's not really fair to compare. But this is as close as it gets, you know. Then you're really comparing two types of cars in the same race with the same length, with the same gasoline. So.
Yeah. But let's say if this would succeed, you see what you want to see, and you would go into a phase 2B, for example, or eventually against phase 3. Would it be an adjunctive therapy? Maybe a silly or a hard word, but for the audience, then it's like as an additional therapy, or would it start to replace something?
In the future, of course, let me start at the very end. In an ideal case, this is a good medicine for the treatment of this particular disease. It replaces, it's an alternative that is good and healthy for everybody. That is the ideal case. But to get there, it's ethically not possible to just substitute some treatment with an experimental medication. So you have to start in a combination. And then you would take a look, okay, if we add adjunct, as you said, our therapeutic option GT002, do we see a little bit of improvement, a little bit faster improvement perhaps? Okay, then we will be able to eventually substitute it, reduce the dose, take away the current treatment, and make a treatment only for this particular disease as an indication with GT002. So it's more of a phasing out. But you cannot go in and say, okay, you stop taking this medication, we give you GT002 and good luck. That is totally unethical. You can't do that.
No, of course. Which stage would that be? Would it be in phase 2 or phase 3 that you would do that?
There
or
would be
it
phase 2.
On
There would be then a larger
phase
2B study, you know, larger group of patients, much more specific what readout you're looking at.
And in phase 2, you would remove healthy volunteers then? It would only be patients, or could it be a mix?
Phase 2, you know, is no more healthy volunteers, and it's patients. It can be other patient groups, you know. But the info, I think it's information we can get out of the clinical trial. You can, because of the neurosignature, I think you can use it for other indications too, which makes it, you know, might be only, you know, or specific to this particular disease. But the information that you get out and the conclusion you can draw from there, it definitely makes it interesting for other disorders, diseases too.
Yeah.
That's my hope.
So if I ask a bit more about the fingerprint, because if you look at schizophrenia, right, it's multifactorial.
Absolutely.
There have been research looking at different points of view on it. What's the thing that's convincing you that this fingerprint could actually, is it an alleviating, or what's the thing making you exciting around
Well,
this?
I'll give you a sort of nebulous answer on that one,
Okay.
but you will get the details in the paper where, because the way the GT002 fingerprint is inducing change in the healthy volunteers
Mm.
makes it really probable that it can be very useful for the pattern and the neural fingerprint that you see in the schizophrenia patients in the particular areas of the brain I'm thinking about.
Okay. I can see you start to
If
smile,
I
but
can
maybe
get
we should leave it at that.
if I can give you that that answer, but I can tell you that, I've looked at all the data, and I've uploaded all the data. I worked a lot with AI on this, and then I literally asked AI, what indications are there that this kind of pattern and this kind of results would make this drug interesting,
Mm.
and pumped up everything. And we can think about AI positive or negatively, but the answer I actually got, let me put it that way, is very much in line with what we're actually doing. It was actually quite nice to get that kind of result. So it's not only my interpretation, what we're going to publish, but also looking around. Key point, and the one thing we always come back to, and where we started our talk, Markus, is cognitive impairment. In schizophrenia, in this particular talk, but cognitive impairment with this kind of fingerprint induced by GT002 can be an interesting indication.
Mm.
And cognitive impairment you have in many disorders, some very severe, some very light,
Mm.
but it's very common.
It feels like I wanted to ask you 100 questions around this neural fingerprint, but I guess we'll have it in the future. And I'll try to read upon it a bit before so I can ask good questions.
As soon as that paper is submitted, hopefully one thing we'll get the feedback very quickly. I think we should definitely have an episode of GIST on this particular neural fingerprint, because it's it's nothing I had planned. It was nothing that I had in any strategy meeting. It's nothing that we said, okay, this is what we're going to do. It literally came when I was looking at the data that we got from the clinical trial in the healthy volunteers. And I thought, wait a minute, what is this actually? And I started looking around, talking to people, getting some expert input into this, and said, oh, this is really, oh, this fits really nicely. Then I got the idea of the patent. Then we got the idea of the publication and so on. But this was, at the same time as we were doing preparing for the trial in Denmark,
Mm. And this
It's
came out
crazy.
of the collaboration with Mindig then. Is that like what enabled you to come up with this?
Absolutely right. So it was been the talks with this guy, the insights we got, we went to the EG summer school. I mean, we did learn something at that school, and I suddenly could see, wait a minute, this is really a potential. And then I really got quite enthusiastic about it. Yeah.
I have a couple of last questions, and usually you should always ask this question if you look at the protocol, right? What's kind of the highest risk with the study? Because risks are inevitable, right? There would be risks.
Absolutely. The risk is that, the data generate don't fit with the data you have seen previously.
Mm.
For example, that the baseline in the patients that we get in does not fit with the baseline of people that done other studies in schizophrenia.
Mm.
That's already there's a problem. There's not so much you can do about it, But if you talk about risk, but that is more a risk of that is common, I think, to any clinical trial in many disorders, in particular CNS, where there's the sort of cognitive research and so on. That is definitely a risk. But thank God we have de-risk as much as possible that something can go wrong with a drug or a side effect or something like that. So there's a minimal risk in that left, because you don't know. But from an operational point of view, it's a variation.
Yeah.
It is, I don't know what effect there can be of current medication.
Yes. But I saw also that you had
I
a
cannot
big health
control,
check, right?
yeah, but you don't know what people do as soon as they leave the hospital. I don't know.
Of course.
You don't know. It's
Yeah.
again individual variation. I think that is the variable number two. One is the technical approach, The number two is, does it fit with the current literature? What have we seen before? That's the nature of science. People have different findings, and then you can discuss, okay, why? But it would be nice if it fits that what we see. Okay, the baseline is what we have seen in other observations too, and that we see a good effect with GT002.
Mm.
Experimental medicine, Markus,
Yeah.
that's where we are.
I think that in my point of view, I'm very happy that the study is comparing the individuals between different events, or what would you say,
Yeah,
different
yeah,
visitors. Because if you look at other studies that's been made, it's looking across a population of
yeah.
patients or healthy volunteers. It makes it extremely hard to rule out all the different deviations between the individuals. So I'm very happy with the study that it's actually comparing each individual with different modulations
Exactly,
and
exactly.
treatments.
And you're exactly right. I mean, Mindic, they had a very nice application where they were actually trying to see if you can normalize, the signals in a larger population, EEG, for diagnostic purposes. And there the problem is that the number of patients that you need is so big, because of
Mm.
variation. Soon as you go out into huge group, it becomes really, in our case, also not really feasible. It's not what we can achieve with the resources that we have now. Not that we actually even want to, because I mean, if you're trying out something in any project, in anything, you always want to start small and say, hey, does this have a chance? Is this actually working at all? And once you see opening there, then you go in that direction.
So I guess we have had a lovely time, but I'll be thinking how long the audience are willing to listen. So my last question is there anything that you'd like to say of the start, or what's the current status of starting the totem study?
Yeah, the totem study had this delay because of the problem with the production last time. So what we did, and I would like to say is, literally, when you have a problem at the very end of a process, you have to go all the way back to the process to solve the problem. What was the problem? Really solve it, and then you have to walk all the way back on the way. And we literally have done that journey all the way back. Everything green until now. We're at the very end, the production, and will be some quality control issues left, and then the stuff is in Denmark. I'm in the clinical trial material is sent to the clinic, but I'm in touch with both the producers and the clinic, so I'm a little bit in the middle of this, and we're almost there, and I would definitively communicate as soon as the material is in Denmark and the first volunteer comes in. I don't want to give, any deadline, but I can tell you that it's very close. We're talking a couple of weeks.
Yeah.
And when we walked all this chain back, I have to say that we have retested and retested and retested, and on the way, not only were all the results good because the material. Remember that we have 800 gram of API, active pharmaceutical ingredient, in warehouse, which is worth a couple of millions. And the good thing is that we did stability tests. So this GT002 is very, very, very stable, which is very
Mm.
nice. So we don't have any issues with warehousing this compound for years. Number
Yeah, that's
one.
great.
Number two, production that we have done now, and I think that's important to know, is that the production we have done now, the material that we have, is more than sufficient for this particular trial. So we can see if we can use the same material with the same quality assurance, quality control for other smaller trials on the way as soon as we started the Denmark one. So it literally is one step after the other. But as soon as this trial is on its way, we take a look at the other trials. Like I said at the beginning, FTD was an interesting stuff. There are other things too, because having a validated clinical trial material candidate is actually quite interesting and attractive for other people, that there are not that many experimental safe medicines to test if you are interested in, I don't know, something completely different. Say you're interested in migraine and you have a theory that GABA might be involved in the treatment of migraine. I'm not hypothetical now.
Yeah, of
And
course.
you said, okay, it would be interesting, this GT002 compound from this little Swedish company called GABA, that could have an interesting profile. They have a clinical material ready. Okay. Then it could be interesting. Hey, contact me and say, we have this project, what could we do? And we can start talking. So the possession of a clinical trial material that you can use for clinical trial in different indications that is safe and good and validated, orally available, is actually quite attractive.
Yeah.
No, it doesn't have to be big partnership, can be, academic groups, people that are interested in, have a certain theory about, I think that GABA is involved in, I don't know, some other disorder they're interested in. But to test it in a patient, you need that material, which we have done, I don't know how many quality controls by now. So this stuff is really as safe and standard quality, GLP, GMP, and so on level. That's good. It's a good thing to have. It's an asset.
Yeah, of course. Then the last question, I feel like I'm saying that all over.
Yeah, you have
I
said
haven't
that
asked,
all the time. You started by
but
asking the last question.
I don't know, but what's your background? It feels a bit embarrassing asking that in the final minutes, but what's your background?
No, I just get out of the picture for 1 second. You see, what I try to do with AI, I was trying to, how can I visualize a neural signature or neural fingerprint? How does it actually look like, And if you look at my background picture, if you compare two brains and you see a little bit the different light activities, maybe blue is low activity, red is high activity, and the different areas are little dots that talk to each other. And that is a snapshot in time. That would be a certain activity, a certain signature of your brain at a certain moment. That was what trying to do. It took me hours, but it's very difficult to.
I was
It's
thinking
very
for a
difficult
while
to.
maybe your brain activity after listening to gist would just increase after 2 hours.
I think it should stimulate you.
Yeah.
So would be more excitatory input, and then get some ideas, and hopefully, become interested in our process, in the journey. I don't know, the pattern on the neural on the neural fingerprints is, many people would enjoy this. Actually, it's like an exploration. You go out, roughly where you want to go, and suddenly you find something and say, oh, this is really interesting, and you follow it that way. So
Yeah.
it is quite enjoyable activity. I think people would like it.
On that note, I'm looking forward to have more regular meetings. It's been a hectic time for you with the financial round, as we mentioned in the beginning of the session.
Yeah.
So, and I'm looking so much forward to record another session, but I guess this needs to be the end of today's session. So if you have been listening until now, thanks for hanging in there, and then see you next time maybe.
Exactly. If anybody actually is still listening to this, then I really thank you. But big thanks anyway to you, Markus. I must confess that I really enjoy these sessions. And I give many presentations. Sometimes I feel it's all I do all day long. But this ones I really look forward to and enjoy every time. So it's brilliant.
Cool. Then I'll try to keep it up for the next session. Okay.
Okay.
Okay. Bye.
Bye-bye.